Hello and welcome today to the Anatomy of the Unnecessary Recordable OSHA Outcome Follow-Up live stream. We had so many questions on webinar that we felt like that we needed to follow up with you before you head into your holiday weekend so that we can get you some answers going into that. So we're thrilled that you've joined us. We're going to go through some additional questions that you guys had about OSHA recordability and also some heat-related topics. But I do have our panel that's here with us today, which is Chief Medical Officer Dr. Scott Cherry and Chief Marketing Officer Dara Wheeler, and I will let them introduce themselves. Dr. Cherry, you want to go first?
Sure. Thanks, Holly, and good afternoon, everyone. My name is Scott Cherry. I'm Axiom's Chief Medical Officer, and me and Dara always kind of are playing with our dual CMOs, so I misspoke there. But my professional background is I'm board certified in preventive medicine, public health, and occupational environmental medicine, and I've been helping either the U.S. government, military, corporate, and industrial operations for the past 15 years in that role, and it's a pleasure to be with you.
Fantastic. Dara?
Thank you, Holly. Hopefully everybody can see me okay. I'm having a few technical issues. My name is Dara Wheeler. I'm Axiom's other CMO, like Scott said. I have been with Axiom going on almost 17 years, and I'm excited to be here today. Thank you, Holly.
Awesome. Well, thank you, Dara. And my name is Holly. I am Holly Foxforth. I'm a registered nurse, and I am the marketing manager for content. And we love these webinars and also the live streams to be able to connect and with you guys and chat about some of the issues that you're having on a daily basis. So we're thrilled that you're here. Give you kind of a shout out to everything that's going on. This next week, we will start in on some travel. If you were going to be at ASSP in San Diego, actually, I think it's San Antonio. I misspoke. In San Antonio, we would love to see you there. If you don't have tickets, please contact us. We can get you some for that, for the expo there. And then also the following week, we will be in Las Vegas for SHRM 2023. So if you're in either of those locations, please stop by. We've got a beanie with your name on it, and I would love to take a picture with you while you're there at the booth. And then in addition to that, we're going to have a venomous foes, understanding venomous snakes and spider bites for our next webinar in June. So we hope that you'll join us for that. All right, jumping into the questions. Dr. Cherry, I'll come to you first. And we've had a lot about OSHA recordability. There was one in here specifically that was about leave of absence. And they were talking about whenever we had, I think it was Dara that had referred to it initially, in the loss of muscle mass. And how is it that you can expect employees to return to that? And so the question was, if an employee is on leave of absence and experiences a physical decline, when should they be held accountable to performance metrics and quotas?
Yeah, that's interesting. It depends on kind of I guess that there's a lot of nuance there, but in general, whenever someone does return to work and they've been fully cleared, or if it's I guess absence any medical indications that they have light duty or transitional work, like they essentially should be held at the same level as before they started working. And so that's why I say this is nuanced, because it's important for every employer to have policies in place with HR that deal with leaves of absence, right? And so if you don't have a policy, you can quickly be held out for discrimination, where maybe a lot of the times nothing really happens, and so you get comfortable or complacent. But then if someone returns and is not performing, then if it becomes a performance issue, they may raise it as a medical issue, and then it just becomes very convoluted. And so my recommendation would be to have HR policies with regarding to leave of absence for those that have, physically demanding work, safety sensitive work, and even psychologically sensitive work, that, there is a formal return to work policy. That way people can return to work through that process. For physically demanding work, you could actually also have an additional layer of what I call quality, where someone is cleared to return to work, but then they go through a functional capacity evaluation just to make sure that there's objective, measurable information that they can perform the essential functions of the job adequately and safely, because there can be a deconditioning, even if they're fully cleared medically, there can be a deconditioning period if it's very heavy work. And so if they've been out for an extended period of time, deconditioning can happen where their cardiovascular system or their musculoskeletal system just, starts to atrophy and potentially have that issue. So this is a nuanced approach, and so I think it's hard to answer in a vacuum, but those are things to think about.
Excellent points. Excellent points. All right. We've had a lot that we're asking about recordability. So I'm going to give you some rapid fire questions here and that we're asked. And you tell us if they're recordable or not, or why, etc. All right. The first one, when a doctor prescribes a medication, is it recordable if it's not filled?
It is. So once a doctor either diagnoses a serious medical condition, which is kind of vague, right? Because that's still into interpretation in general. But if a prescription is written, then it is going to be considered by the letter of the law or the rule recordable.
Mm-hmm. What about a chipped tooth? This is always an interesting topic about the teeth here. So if they did not seek treatment, but they did have a chipped tooth, is it recordable?
It is. It's actually specifically discussed at one of the OSHA regulations. So even if they don't seek treatment, it's still considered a significant injury.
Good. Okay. And then what happens if an employee seeks medical treatment without the consent or knowledge of the employer? If it was for a work-related reason, is it still recordable?
From my understanding, yes. So the point of that really is to really have a good system and culture in place to where that really is minimized or eliminated, right? I think the number one reason, I think there's two big reasons why people do that. There's either they don't know the resources to use, or they're not supported, or they don't feel like they're being taken care of. And so they can, through the workers' comp system, some states will actually have choice of doctor by the actual injured employee. There's kind of a mix across all 50 states of rules, but regardless of if it's covered under workers' comp, I think the OSHA recordability by the letter of the law, if the same thing applies, if they go to a doc that's very goes beyond first aid, then it's going to be recordable.
Agree. Yeah. What about, let's see, there was one that was asking, could butterfly band-aids or butterfly strips create a recordable event?
So those two are specifically listed as first aid under the OSHA list. So, I think on average, and for the majority of those cases, they're going to be, first aid. If it's, like a massive laceration, then if the doctor feels like it's, a significant injury, or if just the facts of the case kind of rise to that level, so you still need some nuance about that. But in general, those two, you have just administrative fouls where it's like ibuprofen at 800 milligrams versus 200, right? But there's a nuanced approach where, again, if you're, the injury, the severity of injury does matter.
Yeah. And the antibiotic prescription, the prophylactic antibiotic prescription is usually where they get tied up a little bit on that one, isn't it, Dr. Sherry?
Yeah. So just to double check. So really the only preventive medication, if we're going to say medication, is a tetanus shot. So any other vaccine, which is not an antibiotic usually, but any prophylactic antibiotics is also going to be considered that as well.
All right. Dara, got you on cell phone. Oh, good. All right. We're going to bring you in on some of the ones that are coming up next. All right. Another one was they had a fracture. They'd taken an employee to a clinic visit and they were diagnosed with a fracture. However, they had another repeat x-ray and it was later determined not to be a fracture. And so the question was, does that still have to be recordable? How would you handle that?
Is that to me or Dara? Or
we'll go with you on this one and I'll come to Dara on the next one.
Okay. So I think really having an accurate diagnosis is kind of the hinge pin on all of the, especially what we're speaking about today, but obviously in our incident case management. So if it was a true misdiagnosis, and then, the accurate diagnosis is not a fracture and it's not something else severe, I think that, it could be administratively reversed or never recorded, as long as there's good, I think, supporting documentation about that.
And Scott, as long as I don't use anything to stabilize that would prevent the movement, right?
Yeah, like a rigid splint versus a soft splint, and so there's multiple layers to all of this. So we're usually kind of looking at one piece in a vacuum, right? So it's, if they got 800 milligrams of Motrin, it's recordable even if it's not a fracture, right? And so if it's just a sprain, not a fracture of the ankle, but they have a rigid ankle boot, then it's recordable, right? And so if they've given, low dose, non-prescription strength medication, a soft splint, but then it is a fracture, then you would also say that's a significant injury. So, these are kind of in a vacuum, but you have to look at all the layers of the onion and look at the total onion, so to speak.
Mm-hmm. All the more reason why you need somebody on your team. You need somebody in the boat with you whenever it comes to some of these injuries, because trying to navigate those independently can, you can kind of run into some roadblocks there. Mm-hmm. All right, Dara, I'm coming to you next. And this one was specifically how it is that they can approach clinics to work with them on recordability issues. And so, you do a lot of work with new clients that are coming in and explaining to them how it is that we ramp up, what it is that we do, and how we communicate with clinics before our nurses are contacting them. So do you want to go into that a little bit further on how it is that we communicate and why that process is so important?
Yeah, I mean, I know a lot of clients, I think the gist of the question was they want to know how they can build those relationships. And I know a lot of what our safety teams out there are doing, especially when you set up a job in a new location, is finding the local clinics, like the local occupational health clinics that you potentially might want to work with, and going there and telling them about who you are as a company and the support you've got from a company standpoint. Now, that can be hit and miss on a relationship building standpoint. And sometimes it's because the clinic doesn't want to speak to somebody that's non-medical, or feels like that's not the place of the supervisor or the safety to have that kind of conversation. So we do a couple of different things. If clients have clinic relationships that are long-standing or really positive relationships, then what we do is we put that into our system as a preferred provider. And chances are they're probably already in our system as a preferred provider. If there's an area that it's new for the client or new for Axiom, what we do is when we set up that location, we proactively reach out to the clinic and make sure they can perform various diagnostics or things like x-rays. We want to document what capabilities the clinic has, so that when our nurses are trying to potentially send an employee there, we know exactly what type of capabilities the clinic has and how likely they are willing to be able to work with us, and how much they understand the work-related component of these injuries. So we attempt to do most of that ahead of time, and that relationship building over time. Axiom's been doing this over 20 years. Like I said, chances are in most of these locations, we probably have a clinic that we like to work with. And on the flip side, we also like to document feedback from our clients and our nurses on the clinics that they prefer not to go to. So we also document the avoid clinics. And often it's just making sure that even if we've tried to educate a clinic or the providers, they don't really have a good collaborative relationship with our team or with the client team. So we try to avoid those clinics that give the prophylactic 800 milligrams just in case, or the antibiotics just in case. So it's building those relationships across the U.S. and making sure that we know who is willing to work with our team and with our client teams ahead of time.
And to just kind of go with that a little bit further, one of the agency professionals was asking, how is it that and how would they go about intervening in a situation without violating HIPAA? Do you want to speak on how we manage that piece?
Well, there's a couple of components. HIPAA doesn't typically apply in a case of a work-related injury to the extent that it is in treatment or relationship to the injury. Now, that is very complicated when you're trying to manage an injury, because where does that leave off, and how much information can you ask? So although some clinics, like I said, will be willing to work with safeties and supervisors that want to attend the appointment with the employee or want to go to the clinic with the employee, a lot of our clients' standard practice is to attend with the employee to make sure that they get taken care of or pay for the visit, different things like that. But it's very kind of hit and miss on what clinics will be willing to work and communicate directly with the supervisor of safety. A lot won't. And so when you have that medical to medical conversation, somebody from Axiom, a nurse, has a conversation directly with the medical team at the clinic. Usually we're able to dig in a little bit more and get more information. Our nurses are also evaluating medical history and making sure that the communication about an employee's medical history stays between nurse and employee, just so that we're not violating any of those privacy components. But it is all in the relation of a work-related injury. So as long as there's kind of this need to know, but it's still tricky. So that's why the Axiom nurse is involved. For example, the example we usually use is diabetes. That might not directly relate to the injury, but it might relate to how seriously we need to take the injury or the treatment of the injury. So the Axiom nurse may be asking an employee some of those medical history questions that at first blush doesn't seem like it might even be related to the injury, but it's important to know so that we can provide correct guidance for that employee.
Absolutely. Yeah. And in case you didn't hear it, in case you missed it, the secret is in the nurse speaking with nurse to nurse. When you can go nurse to nurse and speak with those providers, that's usually when you have a little bit better outcome there. Great information. All right, let's talk about how it is that you manage a case. How does Axiom manage a case when the employee doesn't want to follow first aid recommendations?
I can start. I'll start and let Scott jump in. This is a really big piece of why we like to educate ahead of time, so that employees know why it's important to follow those first aid recommendations. So education ahead of the injury, making sure they understand the relationship, why we're there, and how we manage and why we manage these injuries. But also the first thing the nurse is doing when they're on a call with the employees, making sure that they're educated about the progression and why first aid recommendations are so important. So a first aid recommendation in a vacuum isn't going to really do much, but if you are able to help educate the employee and maintain that compliance, that's when the injury is able to progress towards healing. So is that perfect every time? No, and we don't claim that that always works, but making sure the employee knows they have resources is really important. And if they go home and are concerned, or if their family's concerned about those recommendations, they have a phone number to call, they know who to reach out to. And that's really critical in this experience too. So we just have a really high rate of compliance with our recommendations. And I do think that really encourages the next time, and all these relationships and these experiences build over time, and employees, they talk, and that culture shifts pretty quickly within organizations. Dr. Cherry, anything else there?
Yeah, kind of just echoing along those lines that we know through our kind of robust decades of data that late reporting causes increased recordability. And I think a big contribution to that is rapport and reassurance and also support. So, if the best is if an injury can be called in really just contemporaneously, right when it's happening. And then there's a lot of, I think, at minimum reassurance that, it's been triaged for it to be a severe injury or potentially minor. And because if the opposite happens, if it festers for hours or days, once the mindset shifts to no one's caring about me, I need to take care of myself. And it's like, the medical resources out there are even almost overwhelming for me when I'm having my own medical issues to go out. So let alone someone who's not in the medical field, and maybe in a smaller town or away from home. So really, I think really the best way to prevent non-compliance is really early access, early intervention.
100%. And Dara, to expand upon that a little bit further, we had a question about third-party injury managers and the perception there about, how do you tell employees that it's in their best interest to have a third party? Any recommendations?
I'm that question was a good one, and it's one that again, it's that cultural shift to education. I do think, sometimes there might be this initial perception that we're the company doc, we're the company nurse, we're just there to do whatever the company tells us to do. And the difference with a company like Axiom specifically is that we are a best practice organization. So while the nurse is educated and understands the impact of OSHA on the business, understands these business outcomes and how critical they are, they're also there to support the employee and the employee process. And so it's balancing both really well and making sure that everybody involved is kind of getting their needs met and making sure that because we take care of employees first, the business outcomes are there. And it's that caring that we provide to the employee in the process that allows us to develop the relationship in a way that provides those best in class outcomes. So I do think the proof is in the experience. I think what I'm hearing from a lot of new clients is kind of prove it. We've never seen this be like, yeah, right, okay. But we have seen that if we can deliver a service to an employer, then the proof is in the experience and the outcomes.
Wouldn't you say it has to do also with that relationship building that just like that saying that nobody cares how much you know until they know how much you care? It goes a long way.
Exactly.
Yeah. All right, Dr. Cherry, let's go back to you about some recordability here. Let's see. There was another one that was asking about ibuprofen 800, and they were asking, is there anything that would have the same effect as the ibuprofen 800 milligrams?
Yes, there is. I probably will hesitate to give actual medical advice, but there's definitely strategies for pain management through over-the-counter medications and through other kind of strategies as well. So there's definitely like several choices there. So that's kind of why we are very passionate about the work we do, is because we can actually maybe even provide a better result, a better pain management strategy that's actually not going beyond first aid. So it's less impact to the injured employee's physiological system, and they're actually managed much better. So,
and sometimes people don't need to be on ibuprofen if they've got a stomach problem or bleeding disorder, et cetera. Sometimes they need some additional medications. They've got stomach ulcers, et cetera, that may need something that's a little bit different. Yeah, great question. Yeah. Okay, all right. Can you tell us the difference between first aid recordable and then also restricted and lost time?
Oh, okay. So maybe I'll work backwards. So the last two are maybe more straightforward. So if the employee's taken off work, that's lost time. If they're issued medical restrictions, then it's restricted work, and so those go into OSHA recordability. And so essentially, from the medical aspect of an injury, if you're trying to keep it not recordable, you essentially want the criteria needs to be met that you do not give medical treatment beyond first aid, and OSHA has a list that's considered first aid only, and anything else that's not on that list is considered medical treatment beyond first aid.
Excellent. All right, and then one last question about recordability before we moved on to heat injuries, and that is, can you explain how the process works for medications that are given for diagnostic purposes? So there was a question about CAT scans or an MRI, and so I would assume that the CT is related maybe to the contrast that's administered. So when it's given in a diagnostic format like that, would that be recordable, and why?
I may need to think about that a little bit, but my gut is, well, what I know is that just diagnostic imaging, getting X-rays and CTs are not considered medical treatment beyond first aid. I do, once you kind of get into like MRI with contrast, that's kind of interesting just for other reasons. Like, is this a severe injury with severe symptoms? But my gut is it's probably not recordable either if it's just purely diagnostic and it's a negative, exam or an exam without findings for a diagnosis. But I haven't thought about the contrast component of it. So that may be something. I don't know if, Holly, off the top of your head, or
I'm not thinking that it's recordable. If it's specifically just for recordability, for diagnostics, I'm not of the understanding that it's recordable. But yeah, I can look at that again too as well. Yeah. All right, let's talk heat-related injuries. Dara, what kind of resources do we have if somebody has questions about heat-related injuries?
Axiom has a couple of things. We've got a heat card that helps both on the prevention and treatment side. So what to do to prevent and what to do if you start having symptoms of heat-related illness. Got a bunch of content, webinars, and different pieces of information out there. You can always call us if you need more for that side of things. But we definitely like to work with our clients before summer hits really badly, and we can get some of those resources out there if you don't have them.
Absolutely. Do you want to give us a quick summary of what we had gone through in the webinar about the heat-related injury, about the two scenarios that we had that had occurred on the same day?
Yeah, we had a client who gave us this case study. They had two employees almost on the same day, I believe. That one employee, they're both experiencing similar symptoms of heat illness. One employee was taken to the emergency room immediately, and they, as Dr. Cherry so clearly talked about in the last conversation, when you present in an emergency room, they're going to try to rule out all of the things that it could possibly be, including heart attack and other cardiovascular issues. And so they prescribed, they treated him with fluids, they treated him with all sorts of different things, assuming that he was potentially having a heart attack. They eventually diagnosed him with heat illness, and after that, the bill in the emergency room was pretty significant. And the other employee called us, and we started him on some first aid recommendations, got him in a cool vehicle to cool down, and the subsequent case was very minimal. I think it was less than $1,000. So an example of these scenarios, although it's really important to get somebody medical on the phone with that employee, because you're not going to be able to differentiate necessarily between heat-related symptoms versus potentially something more serious. That's why you have a medical partner help determine what the next step should be, whether an emergency room could be appropriate, or whether first aid recommendation and keeping that employee cool for a little bit is the right way to go.
Absolutely. Yeah. Dr. Cherry, somebody had asked, is placing the cool rag on the back of the neck effective for cooling measures?
Probably. Again, I think it's a little bit nuanced. You want to look at the whole picture. There's really like a set of things you need to do in general, but I think that's potentially part of it. So the higher level of expertise you can engage to kind of make sure you're doing everything possible for that person is really key. If you're doing that, but you're leaving them in the sun, That's, so you kind of, you want to make sure that, if someone really is starting to show signs of heat stress, that, you really are taking it seriously and getting like, expert kind of guidance versus just, maybe just piecemeal approach. So that's why I said it's probably part of it, but you want to have like a comprehensive component. I think what a lot of people don't realize with heat stress, and I have a lot of experience with heat stress managing soldiers when I was active duty, is that medications, alcohol use, allergies, new environment really dramatically change people's resilience to heat stress. So I think we see it every year where, summertime hits. And so it goes from, potentially 60 or 70 degrees to 90 or 100. But people can actually have heat stress in 70 or 80 degree weather if they're doing heavy work, if it's new work for them, or if they're coming off a long or if they're coming from a return to work where they've been deconditioned, sitting in air conditioning for 3 weeks, and now they're back into the outside environment. But just taking some of the antihistamines dramatically change your ability to cool. Alcohol specifically turns on your kidney to dehydrate you. So I know a lot of people will think drinking beer at night is a way to hydrate, but it literally is turning on your kidneys final mechanism to where you actually are losing water much more rapidly than you should from a purely physiological level. So again, I think it's and other medications can really affect that. So, heat stress can become deadly. And so it's something that I think is common. And so people get complacent, but you can have like what they used to call heat stroke, which is severe heat stress, which is basically a heat injury with altered mental status. So like if the person is not making sense, not acting themselves, that's really a medical emergency.
Yeah. What would you say are the most common symptoms that are overlooked early on in a heat-related illness?
I think just headache is probably one of those super vague ones that, it's like, oh, is it a hangover from the night before? Is it not sleeping well? Is it jet lag? But headache, just very vague symptoms, almost like an illness, like a viral illness, like nausea, fatigue. And so fatigue is kind of interesting because I think we're all fatigued potentially out there. But if you have true fatigue that you're just trying to muscle through physically or mentally, that can also be a sign of it. So a lot of the symptoms are very vague. So you kind of need a nuanced approach to the assessment. So
yeah.
I really like your point, Scott, about the behavior from the night before could really affect. I think that's really important. So it's the behavior leading into the activity, especially if you're working outside in heat. It's not all of a sudden hydrating 5 minutes before you go out there. It's making sure to have been hydrating the 24-hour period prior, not just right before.
Mm-hmm.
Yeah, in fact, some interesting, you can use some objective metrics, which may be interesting to discuss. So like just body weight, if you're not trying to lose weight, but you're like 4 to 5 pounds lighter than the day before, like that's a half a gallon of water that you've been dehydrated. So a gallon of water is 8 pounds. So, if you're 4 pounds light and you're not trying to lose weight, if it's from one day to the next, or you can do it at the beginning of shift and at end of shift, right? Most people usually gain weight during the day just because they're eating, and they'll lose a little bit overnight just because they're breathing off water. But if you're losing significant amount of weight and you're kind of in the heat, you are actively dehydrating. And so, you're not going to rehydrate yourself drinking alcohol for one, but that'll actually just exacerbate it. But it will take you quite a while to rehydrate that level of volume.
Mm-hmm. What should your urine look like? I know this is kind of an odd question, but what should your urine normally look like? You would know what's
I think
right.
People might not actually pay attention, or it's just kind of a casual observation. But The darker your urine is, that means it's much more concentrated. And so your kidneys are working overtime to reabsorb water in that final cascade of as it's filtering. And that's what alcohol actually dramatically turns off that function. So you can actually, if you're, so here's a 2-for-1 kind of, so your water should be, your urine should be fairly clear. But if you're drinking alcohol, your urine will actually be clear, even though you're probably dehydrated, because it actually is adding in water to your urine versus reabsorbing it because you're dehydrated.
Excellent points. Those are good. Yeah. Dara, anything else you can think of with the heat-related injuries that we didn't cover that we should have?
No, I just want to say I was listening to a Danish researcher about heat and cold exposure for different metabolic reasons. But one of the things she said is they had a Scandinavian saying that as you near summer, you should add clothes, and as you near winter, you should remove clothes. And it's obviously it sounds more interesting in Scandinavian languages, but I thought it was a really cute thing that the more you can get acclimated to the weather you're dealing with, the better. So as we near summer, it actually seems counterintuitive, but try to kind of maybe go outside sometimes with some extra layers so that you can get used to the heat. I know in the South Texas area, we're nearing summer, and I do find that if I can acclimate a little bit better, quicker to the heat, that my training outside during the summer is better, or any work activity is better.
That's a really good point. I never even thought about that.
That brings me to my little leave. I observed the opposite, like especially here in Houston, where it's really warm, except sometimes in the winter. But you'll see people wear their winter clothes, like from their car to their office, or but they never take their clothes off. And so now they're wearing a level of cold protection in a warm environment. So that creates your body to be giving off tons of heat, and you're like vasodilating, you're trying to get rid of all this heat. And then you go back out into the cold. And so now you're even more susceptible because you're essentially like in a sauna. And so that's just where this came from is my wife always bugs me, like, why don't I wear a jacket in the winter? And that's like, well, I'm only going to be walking from the car to the mall. So it's like I can survive a minute of 50 degrees, but I don't want to carry my jacket. But I see a lot of people continue to wear like everything. And it's like when they go back out, they're going to be super susceptible to the cold.
And apparently the shiver reflex we want to encourage. So I guess all of those of us that are wimps now in the winter need to start getting more acclimated to shivering and that shivering reflex.
Yeah. We all had a grandmother that said, put something on your head. Every grandmother's always trying.
Which apparently doesn't work as well as we thought it did.
Exactly. Thank you both. You've done a fantastic job. I appreciate your taking the time out on this Thursday and to answer these additional questions. So again, if you are planning to be at ASSP the following week, we hope to see you there. Please stop by the booth. We'd love to see you. And we appreciate your questions. We hope you have a safe and happy holiday weekend, and we will see you then back here soon. Bye-bye.